So welcome to our program. Hello, everyone. This is the Geriatric Research Fellowship program, Saturday Zoom meeting. So today we will have Dr. Philip Fung and Dr. Slafa will give us a little bit introduction about him. When you are ready, Dr. Slafa, please go ahead. Thank you, Dr. Philip. Go ahead.
Thank you. Thank you so much, Dr. Nader, for the opportunity. I think, in general, both programs share same goals to help IMG to get into residency. Please allow me to introduce Dr. Philip Fung. He's academic hospitalist at Denver Health. He's medical director of Colorado Work for International Physicians. He's also Biomedical Ethics Committee Deputy Chair at Denver Health Center and Assistant Professor of Medicine at the University of Colorado School of Medicine. I'm also happy to share that he has been named this year's annual Top Doctor issued by 5280 magazine. This magazine for 31 years provide list of the best doctors in the Denver metro area. We appreciate your time today, Dr. Fung, to give us information about CO-WIP program. At this point, I will hand over the discussion to him.
Thank you. Thank you, everyone, for having me. As Sulafa said, I am Dr. Philip Fung. I'm a physician here in Denver. I do mostly inpatient medicine and inpatient palliative medicine. The Colorado Works for International Physicians program is a program that we have modeled after an existing program in Minnesota called the Bridge program run out of the University of Minnesota. Both programs' goals are the same, is to take IMGs who already reside in the state and prepare them for applying to residency, primary care residencies in that state. So our program got some funding from the state. It's actually federal funds that got passed through the state to try this out. And it's a 3-year pilot program right now. We're just finishing up our first year, and Sulafa and her colleagues are in our first group of international physician learners. It's a 9-month clinical readiness program that's done at Denver Health. There's also a preclinical side of it that is done with a community partner called the Spring Institute. The links to our programs, if you guys see it in the chat, are there. We are the second 2 links, but the first link is to the original program. We must give credit to the Bridge program in Minnesota because without them forging the way, we would not know what we were doing. And so we're copying a good bit of what they're doing, and they've been super helpful in guiding us. We are, at Denver Health, the clinical readiness program side is basically a modified, compressed 3rd, 4th year clinical experience similar to what U.S. medical students go through, with a heavy focus on primary care and things that will get you into primary care residency. So lots of outpatient primary care, some inpatient stuff, some emergency room, pediatrics, urgent care, OB, GYN sorts of things that are much more focused on getting people prepared so that they look like, on paper as well as in reality, ready to do a primary care residency here in Colorado. The preclinical side is, like I said, run by our community partners, Spring Institute, which is really mostly for getting people ready for ECFMG certification. So there's, USMLE prep, OET prep, things like that. But that's all preclinical stuff. For our program in particular, we are looking for people who are already ECFMG certified, are Colorado residents, and are looking to do primary care. We welcome all sorts of applications from anyone who meets those basic qualifications. And I have promised that we will review your application for sure, no matter what, as long as you meet some of those basic qualifications. So we don't have other cutoffs. We want to see everyone's applications if you are a Colorado resident, ECFMG certified, and want to do primary care. That is what basically the state has given the mandate to our program to do. So we because we're one of the major academic training centers for the University of Colorado School of Medicine and many of their residency programs, we already have the infrastructure to do a lot of, available to do a lot of teaching, and there's lots of learners here at Denver Health. And so all the faculty that we have in our program are faculty at the University of Colorado School of Medicine. We have lots of experience teaching. we've seen lots of medical students and residents come through, so we know what a good medical student looks like. We know what a good resident looks like. We know what it looks like to be prepared for residency. So we feel very comfortable when we evaluate our international physician learners in our program, and we say, yeah, no, you really need to work on this, because I'm telling you, like, this isn't how residents operate, or this is great, you're already operating well at the level of a resident, keep going, this aspect of what you're doing is just right. So we feel very comfortable saying that. Our program is, like I said, a sort of a modified combination of all sorts of third and fourth year type experiences. It's 9 months, and it's actually paid. Like I said, this grant actually pays a small stipend. No one's getting rich off of it, but you don't have to pay us, and it's hopefully not making it too hard for people to leave their jobs to try this, because we recognize that people are leaving jobs to come into our program, and we, at this time, cannot guarantee any particular outcome. This is a pre-residency preparation program, so you still have to go through ERAS, apply, do all that stuff, interview, everything that a U.S. medical student would have to do, but we just want to make our people as competitive as we can with the U.S. medical students who are applying to those same programs. And that's our goal. I have been talking with the program directors throughout Colorado in family medicine and internal medicine, and they have been very excited about the possibility that they could take some more well-qualified, well-prepared IMGs into their programs. And so we do think that we have their ear and, in fact, their encouragement to make things happen. And so they've even invited us to like an open house they're going to have later this month for all the family medicine residency programs in the state and so forth. So that's the basics of our program. Am I missing anything? Oh, something that's very important that I often forget to talk about is we also have a partnership with a national organization that's based here in Denver called CPEP, which is a major player in the assessment world for physicians and medical students. And so they are our external evaluator, and so their word means a lot to residency programs, and so we have already partnered with them. And so our participants do a pre-test with them, and then not really a post-test, but a later test to show their improvement, and they're evaluated on, what level are they operating at? Are they operating at the level of an early medical student, a late medical student, early resident, late resident, attending, or what exactly level are they working or operating at? And that is something that we hope will carry a lot of weight. Not hope, we know, because again, the residency programs all know about this organization. We know that it will carry a lot of weight in terms of showing that it's not just my subjective evaluation because I love Sulafa, I want to see her succeed, but also because there's an external, more objective evaluator that somebody is going to respect, not just because I like stuff. So, other things about the program?
Yeah, so it's as Dr. Fung mentioned, like it's comprehensive in many departments. Like we got to use how system work here in the U.S. We work it in inpatient, outpatient, in different departments, internal medicine, surgery, emergency pediatrics, palliative, psychiatric. So we got a lot of experience and new skills with this experience. Even we collaborated with other teams, for example, physical therapist, social worker, OT. So we collaborate with them, communicate with them through the electronic medical record. One of the differences that from here and other countries, sometimes the electronic medical record, so we became familiar with it. I'm very comfortable using the electronic medical record for like managing the patient and communicate with other provider and other teams.
Yeah, like I said, the expectations are more or less the same as a third or fourth year medical student, depending on where the international physician learner is in their learning process. But really, we want to take people through as quickly as we can up to the level of a fourth year medical student. We expect people to work hard, see patients, write notes, put in orders, follow up results, call consultants, work with other people, go to meetings, all that sort of stuff. We do lead off with a lot of lectures in that first month or so, first couple of weeks to a month, with lots of, it's a crash course. I call it like drinking out of a fire hose, where we just throw all sorts of information at you, and we expect people to work really hard and to be, and spend time outside of their time at the hospital too, reading just like a medical student would, reading, learning, practicing using the electronic medical record, all those sorts of things. So the expectations are more or less, with the slight modifications for taking into account the fact that it is a cross-cultural and a international experience for many people, that it is much like any U.S. medical student for that 9 months.
Thank you.
Thank you so much for sharing all this information. So the requirement, again, the student or the international medical graduate is supposed to be in Colorado for at least 2 years.
Yeah, so if you go to the website, I'll put the links in again. If you go to the websites for these places, they have all the information there. There's an interest form you can fill out if you're in Colorado, and there's an application process. We're already taking applications for this next coming year. It starts in January and runs through September. We also do residency application preparation. We'll do some interview practices. We will help you with your personal statement. We do all sorts of stuff like that. One of the things that we're trying to integrate that we did not know that we needed to, or did not expect to need to, is that we realized that passing step 3 before applying is very, very helpful for IMGs. And so we haven't been able to integrate as much this time just because we're still doing this, but we do plan on integrating more step 3 preparation into the curriculum. Just as of right now, we're mostly focusing on the clinical aspects of things for this cohort, because that's sort of what we promised them. We want to keep on working on again, making all of our who will participate and go through our program, help them make a competitive and compelling case to the residency program so they can at least get their foot in the door, get interviews and things like that. That's always the first step before you can even match, is you have to be seen by the program and interviewed. So.
Sounds good. Any of the attendees here, any question?
Yeah, and you can put it in the chat, or you can just jump in, either one.
And we have Suhaila here also. She's one of CO-WIP participants.
Welcome, Dr. Suhaila.
Hi.
Thank you so much
How
for.
are you? Hi, how are you? It is a really very good program. We we have a lot of things to do in this program, and they help us all, like attending, resident, student, everyone in hospitals, like in Denver Health, Lowry, urgent cares. They help us, and they're willing to teach us. And really, we cannot thank them enough. Really, it's very good program. Thank you for everyone there.
Thank you. Also, thank you so much, Dr. Suhaila, for sharing this note. So if anyone has question, please use the chat or raise your hand or jump in, use your mic. So this session will be recorded for other fellows in case they come late, but for now, let's ask Dr. Lema, go ahead.
Thanks so much, Dr. Nadir. Thank you all for good information. I think it's an exciting program as well. My question is, there may be some applicants interested in the program, but not residents of Colorado. So is the program considering to include those applicants who are already residents in other states of the U.S.?
Yeah, because these are state funds, and because of the way the grant was applied for and written, we basically at this point in time can only take people who are already Colorado residents. If this program continues, because like I mentioned, this is a 3-year pilot program, there have already been discussions because of the large amount of interest that we've had from people in other states. We are considering what it might look like if the state could be our obligation is to, because of how the grant is written and who's funding it, our obligation is first to Coloradans to create more primary care doctors in Colorado. And so we're talking about how there might be ways to be able to accept people from out of state if they are willing to stay in Colorado and how to ensure that that happens. But yeah, like I said, at this time, we're not really looking at applications from out of state. I mean, you're welcome to put it in, and I can't say that I would never accept someone from out of state, but it'd have to be a really, really compelling application with really, really good proof that they would stick around and stay in Colorado. One of the reasons that, like I said, our motivation for limiting it to the state is because we know even for U.S. students who come, many come, do residency here, stick around for a little bit, and then leave and never really stay. Just because Colorado has that sort of draw, especially for young adults, is it's kind of a cool place to come when you're young, when you're single, maybe when you're married with no kids, but then often people will move later on in their career back home, and that's not quite what we're trying to develop here through this program. We're trying to create long-term primary care physicians who are dedicated to the state of Colorado, and one of the easiest ways to find people that way is people who are already here and who have already been here for some years. I want to say our average length of residency for most of our applications of living in Colorado is actually more than 4 years of all the applicants that we get. So I'm sorry to have to say this, but yeah, out-of-state applicants are not going to be at the top of our list at all. So again, I can't say that I'd never take one, but it would be very, very unlikely.
Thanks so much.
Like I said, that's for this first 3 years of this grant, because this is what the grant covers. We have talked about in our own meetings about what would happen if we got additional funding, or how could we get additional funding? Could we take people from out of state? How would we guarantee that they stayed? Things like that. So we're asking those questions. I just don't want to tell you anything I can't promise. And so the only thing that I can tell you for certain is that we've talked about it and we are aware of the interest. But I'd be honest and say that you're not going to be at the top of the list. And it would be an unusual situation that we would take someone into the program that is not already a Colorado resident.
Thank you so much.
Thank you for the question, and thank you for the answer. Any other questions? In the chat, there is one similar question, so you already gave the answer.
Yeah, like I said, I know this is not the first time I've had, talked about this stuff, and I've probably gotten, I don't know, a couple dozen just emails asking, I have to be a resident, I'm willing to move. And I'm like, I appreciate that, but our goal isn't just merely to have someone who's already been here, but also to have someone who will stay. And so that's why I've talked with all the program directors in the state. They know about the program, and that's what we're trying to target people who are here, who will then also stay here.
Excellent. The following question I have is, you mentioned Minnesota, and this is a similar program or copycat. Do you know about other states that follow the same, or they have programs, or they plan to have similar programs with your connection?
So people are asking. I don't know of any other states besides Minnesota and Colorado who have the programs. Minnesota also has a residency requirement. When my colleague and boss, the chief education officer here at Denver Health, Dr. Abraham Nussbaum, goes to conferences, he gets lots of questions about this from lots of people all over the country. So it's possible that other people are trying to get funds in their states to start programs like this and so forth. But I think that everyone lots of people are trying different things, right? Tennessee's trying different things. Washington's trying different things. So every state's trying some different things, and not everyone's trying the same thing. But I do think that people are looking at Minnesota and us to see what might our outcomes be, how long will it take to really get people through the pipeline, because there's always a time thing, right? So like when you join our program, you're still not even in residency yet. So that's at least another 3 years after you graduate from our program before you can practice as a primary care physician wherever you are, or at least until you finish residency. So that's a 4-year lag time, right? So assuming Sulafa applies this summer, get matches next year, she starts residency next summer. She's not an independently practicing board eligible, family physician or internal medicine doc for another 4 years from today, basically.
Yes.
So I think there's a lot of questions about whether or not there are faster ways to do things. Could you, like I said, that's where some of the other states are trying other pathways where they are trying to make things faster. Here in Colorado, we have chosen not to do that. I think that we want to ensure that this is not no one perceives IMGs as like a two-tiered system. Like IMGs aren't as well trained as U.S. grads who went through residency. We want everyone to come out being excellently trained, and so that's why we're trying to bring IMGs up into the category of competitive for residency applications, so that they go through the same residency training as a U.S. grad or other highly qualified applicants, right? So that at the end of it, everyone is board eligible, internal medicine or family medicine physician, fully capable of getting any license anywhere, so that they can be a fully unrestricted physician. That's sort of our big picture goal. Again, because we know that the stigma exists, and we don't want people to honestly think of IMGs as less than or second tier physicians.
Great. Thank you so much. Any other questions from the audience here?
I do want to take a moment, because I know lots of people have asked me these questions too. What I'm hearing from our people for primary care residencies here in Colorado, just so that everyone knows about when you apply to residencies and stuff, is one of the biggest things that they're looking for are the people who can do the work, right? So it's not just about publications, it's not just about volunteer stuff, but you need to get clinical experiences in the U.S. and have letters from people who can say, yes, this person can do the work. They can see the patients, they can write the notes, they know how to use an electronic medical record, they know how to interact with the colleagues, the allied health professionals, the consultants and things like that, because that's what you'll be expected to do in residency. So the more clinical experience that you guys can get in the United States that gives you that type of experience, the better off you are in your applications and in your letters. Observerships, as I know they're super popular and I know that they're all over the country, but unless you're actually getting hands-on clinical experience, observerships are not going to be seen in the same light as actual clinical experience, seeing patients, talking to them, writing notes, putting in orders, following up results, all those sorts of things that residents do. And so that's what I think a lot of residency programs are looking for is, can you do the work? Do you understand how the system works?
Sounds good. Thank you so much. And for the future steps, you mentioned the internal medicine route, the family medicine route, any other routes that I know some programs like Geriatric fellowship program, they have similar requirement as you mentioned. They want someone who passed step 3, who has a clinical, who might have some experience, and they can do the work, and exceptionally they can accept them. So any other routes beside this in your, or it depends on the applicant or the participant?
We're not looking at particularly other routes. Again, our mandate from the state and our funding from the state is to create primary care physicians for the state of Colorado. Now, obviously, pediatrics is also primary care. The reason I did not mention that is because the only pediatrics residency program in the state is perhaps the top 5 program in the country. And so we realize that that is highly, highly, highly unlikely to take anyone but the best of any student, US or IMG. And so just like sometimes medical schools recommend that certain students don't apply to certain programs just because we know the odds are so low and so the program is so competitive, we have sort of that same position right now, is that if there's only one program, pediatrics residency program in the entire state, I mean, I'm not going to stop Sulapa from applying if she wants to, but none of our participants have wanted to be pediatricians specifically. But number two, I just know that it would be extraordinarily difficult to get into that program. It's already extraordinarily difficult for the best of U.S. medical students, right? Top 25 in their class of the best medical schools in the country won't necessarily get ranked in that program, right? So it just depends on how things shake out. Could we see pathways to do other things that grow out of this program? We might. We've talked about whether or not we should expand into creating a transitional year, intern year, like grow that out of this program. But again, at this point, we're just coming up with ideas. We don't have any, other than what we have right now, and I can only promise you that's what we have now, and we have for the next, finished year one, we have for the next 2 years. And so that's what I know for sure. I would love to, I would love to have more money and more time to create new things, but that's not what we have right now. And so we can talk about ideas and stuff, but that's what they are. They're ideas. Yeah. And so what I can offer is the clinical readiness program for the clinical experience after you're ECFMG certified, if you're a Colorado resident. And if you're not ECFMG certified yet, the Spring Institute will work with you on the other sort of like preclinical side with the paperwork and the testing and that sort of thing. And again, that's for Colorado residents. So again, I'm sorry that we were not at this time particularly open to out-of-state applicants, but that's what our mandate from the state is for, and that's what the money is for. So we have to stay true to that. So.
The last question I have, thank you so much. The total number of spots that you have, or how many participants you can accept per year?
So we take 4 per year. And again, it's we have talked about whether or not we could expand that or how that might look, but right now it's 4 per year, and that's what the grant was written for, and so that's what we're accepting right now. Again, it may only be another year before we have to go back before the legislature or go knocking on doors or applying for other grants. We might be able to expand that. We have ideas for how, if we were to integrate out-of-state people, how we might be able to expand things that way maybe. We just don't know for sure yet, but for now, the grant that we're on gives us 4 slots per year.
Sounds good. I don't see any other questions. Anyone else would like to ask question?
I can put also my email, my personal email in the chat. If you have any question, you can follow up with me.
You want to log in or you?
Yeah, I can.
Yeah. So if you guys have any questions, you can find the contact information on those links that I put in the chat for our program. You could also email Sulafa. I mean, you have multiple applicants to our program participated in your program as well, so people know about it. We are happy to, oh yes, and Susanna, our program coordinator, is in the chat as well. Please feel free to ask questions. We totally want you to, if for some reason you end up moving to Colorado, be with family for a couple of years, and the program's still up and running, I'd love to see your application. So anyways, yeah, thank you so much for giving us the opportunity to talk with you. I wish you all the best. I know being an IMG is not easy, and it is something of an uphill battle. So I really respect all of you and all of your hard work, and just the amount of patience and diligence and perseverance that you guys show when you're going through this process, because yeah, it's hard for it's hard enough for US grads, and I know it's that much harder for IMGs. So thank you for sticking with it, and I hope that programs like this pop up all over the country to be able to help you on this journey.
Sounds good. Thank you so much, both Dr. Sulafa. Thank you so much, Dr. Fung, for all this information. It's a very informative session. Thank you, Dr. Suhaila. I'd like to be in touch in the future, and if anyone has questions, as they mentioned, have the contact info here. Have a wonderful day. Thank you so much.
Thank you. Bye-bye.
Thank you, everyone.
Hello again, everyone. So we'll move on to our agenda.
Hello, everyone. Good afternoon. My name is Zainab from Green Team. Today we'll be presenting. I don't know who the moderator is, but we're starting with a presentation on nutrition and weight in older adults, and I'll be presenting that with my colleague, Dr. Ahmed. So if the team is ready, I can go ahead and share my screen, or if our team leader wanted to do some introduction before then too, that's okay.
I think you can go in. Go ahead. Thank you so much, Dr. Zainab. When you are ready, you can share your screen.
Okay, I'll just go ahead. Thank you. All right. Is everybody able to see the slides?
Yes.
Okay, so this is nutrition and weight in older adults, and these are the objectives for these presentations. We should, at the end of this presentation, be able to describe the age-related changes in nutritional health in older adults, how to screen for and assess nutritional status. We're also going to talk about some nutritional syndromes seen in older adults, some interventions for undernutrition, cultural factors, and legal and ethical issues. So these are the topics as stated from the objectives. Now, what are some age-related nutritional changes that occur as we get older? First is a change in body composition, some energy requirements, macro and micronutrient needs, and also fluid needs. And we will be discussing this individually in the upcoming slides. Okay, so changes in body composition with age include a decreased bone mass, lean mass, that's muscle mass, and also water content. Consequently, there's an increase in total body fat, commonly in the intra-abdominal areas. So volume of distribution of many medication changes as a result of these shifts. And then creatinine-based dissemination can overestimate renal clearance in older adults. This is because the creatinine-based cutoffs are based on usually healthy adults and who have more muscle mass than older adults. And so because of the decrease in muscle mass in older people and also the interaction of certain medications that they're on with creatinine, sometimes they overestimate renal clearance. So we should be on the lookout for renal disease in older adults. So we cannot generalize the well-standardized nutritional requirements of young or middle-aged adults to older adults. So they basically have their own nutrients needs because of all these changes that we just described. The energy requirements of older adults, they actually have reduced basal metabolic rates as we get older. Because this is a function of the lower muscle mass, as I said. Basal metabolic rate is the principal determinant of our total energy expenditure. So the estimation of energy needs based on body weight is about 25 to 30 kilocalories per kg per day. So we have to avoid, because of this lower basal metabolic rate, the tendency to overnutrition is higher in older adults. So we should avoid overfeeding, but still meeting the basal metabolic requirements. For macronutrient needs, we can go to myplate.gov or United States Department of Agriculture and look at the food pyramid, and they have requirements for the macronutrient needs in older adults. So Food and Nutrition Board of the Institute of Medicine of the National Academies recommends a prudent diet consisting of protein at 0.8 grams per kilograms per day, fat of 20 to 35% of the total energy intake per day, with reduced cholesterol, saturated fats, and trans fatty acids. And then carbohydrates of about 45 to 65% of the total energy intake, with complex carbohydrates as the preferred fiber source to prevent constipation. Fiber, 30 grams per day in men or 21 grams per day in women. Some micronutrient needs, there are different recommended dietary allowances, and the average daily nutrient intake level estimated to meet the requirements of 97 to 98% of healthy individuals in a group. So that's how they come up with the RDAs. And if you want to see specific RDAs for older adults, you can search this website. Now, what are the fluid needs in older adults? And this is really important. So the normal aging is associated with a decreased perception of thirst. There's also impaired response to serum osmolarity and reduced ability to concentrate urine following deprivation. So even when they're dehydrated, they may not necessarily be making concentrated urine. So we have to watch out for dehydration in older adults. So the fluid needs of older adults, healthy older adults without illness, can be met with 30 mils per kg per day or 1 mil per kilocalorie ingested. Obviously, if they're diseased or they're losing more, then you have to give more. A decline in fluid intake can also result from disease states that reduce mental or physical ability to recognize or express thirst, or that results in a decreased access to water. Dehydration is the most common fluid or electrolyte disturbance seen in older adults. Some common signs include a decreased urine output, which we said may not always be the case. They could be constipated, mucosal dryness, confusion. None of these are either sensitive or specific, so we have to look at the symptoms as a whole. How do we assess for nutrition in older adults? We use anthropometrics, nutritional intake, laboratory test, we take into consideration some drug-nutrient interactions, and there have also been multi-item tools that are either self-administered or administered by healthcare personnel that can screen for people at risk of malnutrition. For anthropometric measurements, they're often used to assess nutritional status, and they include the body mass index. Body mass index, as we know, is weight in kilograms over height in meters squared. And the risk threshold for a low BMI is 18.5 kilogram per meter squared or less. But this should be interpreted in the context of the individual's lifelong weight history. So if somebody has been usually on the lower side and has not lost a lot of weight, the BMI by itself might not point to undernutrition. Unintended weight loss of 10 pounds in the preceding 6 months is usually a useful indicator of morbidity. It's predictive of functional limitations, healthcare spending, and the need for hospitalization if it's really severe. The MDS, which is a long-term care minimum data set, is a health status screening and assessment tool that's used for residents in long-term care facilities, so like nursing homes. And what they've come up with is that they consider a weight loss of 5% in 1 month or 10% in 6 months as significant. For nutritional intake, inadequate nutritional intake has been defined as an average intake of food groups, nutrients, or energy 25% or 50% below a threshold of your recommended daily intake. So poor intake is often an indicator of illness. 5 to 18% of nursing home residents do not meet standards for adequate nutritional intake. And this could be because of difficulty either obtaining food or preparing food, or maybe they don't have the resources, or they have limited mobility, or they don't have a good support group, or they cannot prepare or consume food due to various illnesses. So it's important to, when we see an adult presenting with poor nutrition, to really investigate what could be all the possible causes. What are some ways we can test for low nutrition or for nutritional status? So one of the markers is albumin. Now, albumin is mostly it's a protein is produced by the liver, and is a risk indicator for morbidity and mortality. Hypoalbuminemia, it's not very sensitive or specific by itself as a nutritional indicator. However, it could predict, it could be used as a prognostic factor for marker of injury, for disease or inflammation. Prealbumin has a shorter half-life, and it's actually better if measured to reflect the short-term changes as opposed to albumin, but it also has largely the same limitations. Serum cholesterol is another one. Low serum cholesterol is detected in individuals with serious underlying diseases such as malignancy. Acquired hypocholesterolemia, that's less than 160, is a nonspecific feature of poor health status that is independent of nutrient or energy intake, and it may reflect a pro-inflammatory condition. And it's been found that community-dwelling older adults with both low albumin and low cholesterol have higher rates of morbidity and mortality than those with low either one. So, drug nutrient interactions are also an important factor that affects nutrition in older adults. This is because as we get older, there's a tendency for polypharmacy, and a lot of these medications affect one nutrient or the other, and some older adults are multiple medications. So, it's important to look out for some of these nutrient deficiencies in adults taking multiple medications, as we might need to supplement. So medications can modify the nutrient needs and metabolism of older adults. Certain medications such as digoxin and phenytoin, even at therapeutic levels, can cause anorexia. Many medications are known to interfere with taste and smell, others reduce the availability of specific nutrients, and some medications can reduce intake by causing inattention, dysphagia, dysgeusia, or xerostomia. Medications that precipitate constipation can also reduce appetite. So this is a table that shows some of the medications and the nutrients that they interact with. As we can see, alcohol interacts with zinc, vitamins, A's and B's, and folate, antacids, broad spectrum antibiotics, colchicine, digoxin interferes with zinc. So, like I said, sometimes you might have an individual taking one or more of these medications, especially long term. So, it's important to screen for those nutrient deficiencies as they appear, because you might need to supplement. For example, you have a patient who, for instance, has TB and you need to give them isoniazid for 3 months, or 4 months, or 9 months. You need to supplement with vitamin B6 because, they're going to come deficient at the end of the day. These are some other drugs like lipid binding resins, interfere with lipid soluble vitamins. Metformin, which is a very popular drug in older adults for diabetes, could interfere with vitamin B12 and a total caloric intake. It also causes diarrhea in some, which can cause them to lose fluid and nutrients through that way too. Salicylates, SSRI, theophylline, trimethoprim all cause reduced nutrient availability. Now we're going to look at some tools for screening for nutritional deficiencies. The Nutritional Screening Initiative, which is a collaboration between the American Academy of Family Physicians and the American Dietetic Association, it aims to identify and treat nutritional issues in older adults. So they came up with a checklist called the Determine Checklist, which is a 10-item self-reported questionnaire. And it asks, Determine is actually an acronym. It stands for disease. E is eating poorly, tooth loss or mouth pain, economic hardship, reduced social contact, is the person taking more M-SANs for multiple medicines, involuntary weight loss or weight gain, does the person need assistance in self-care, and is the person is elder over the age of 80. So a check mark or a score of 6 and above points to a possibility of the risk of malnutrition. So it doesn't actually diagnose malnutrition. It just tells you who is at risk for malnutrition. There's also the mini nutritional assessment, which is an 18-item questionnaire, and this is administered by a trained professional, And there's a short form, which is just 6 items and can be administered in about 5 minutes or so. And this evaluates the risk of malnutrition also among frail adults and those who may benefit from early intervention. It's available as an app on your phone or tablet. There is also something called a simplified nutritional assessment questionnaire, which can be answered by patients through the mail or while sitting in a waiting room. It has a sensitivity and specificity of about 88.2 and 83.5 respectively for identifying those at risk of weight loss. Some risk factors for poor nutritional status include alcohol or substance abuse, cognitive dysfunction, decreased exercise, because poor nutrition is not just undernutrition, it can also be obesity as well, depression, poor mental health, some functional limitations, inadequate funds, limited education, medical problems or chronic diseases, medication interaction, poor dentition, a restricted diet or poor eating habits, and social isolation. My colleague will continue from here to talk about nutritional syndromes and some of the interventions. Thank you very much.
Thank you, Dr. Elena, for my presentation. Hello, everyone. Is my voice clear? Yeah, okay, nice. So, I will share screen. My screen appear clear?
Not yet.
Not yet. Not yet.
No, Dr. Ahmed, it's not clear.
Yeah. Okay, so now. How about now?
Yes, now we can see it.
Yeah, okay. Okay, my name is Ahmed Mussaad, and I will take the lead from here. Just a quick reminder, it will be an interactive session, so please be cooperative. First of all, I would like to talk about nutritional syndrome. And the question is, what actually we mean by nutrition syndrome? If anyone have the answer, can just raise his hand or come to the microphone. Come on, guys. Anyone, please? Okay. I will assume you are very shy. When we talk about nutritional syndrome, we mean we are not just mean underweight. It's like something like a spectrum to contain who are underweight and overweight. It's all called nutritional syndrome. Okay, are you following me? And when we are talking about it clinically, we are talking about two different cases about who underweight and who overweight. And now we will talk about underweight, and we mean undernutrition. So in clinical terms, when we say something undernutrition, it means that it's a BMI less than 17. And when it becomes something clinically important, when there is a weight loss of about 10 pounds or 4.5 kilogram, or simply more than 5% of total body weight over 6 to 12 period, 6 to 12 months period. Okay. So, an impact of this loss is not just about being small, it's about affect other areas of the body, means of how the body deal with infections, affect wound healing, and also decline in the functional ability, and for sure it is increase the mortality. We have also a term of involuntary weight loss.
I'm sorry to disturb you, doctor, but I think can you just increase your voice a little bit? Thank you.
Okay, thank you. When we talk about involuntary weight loss, in percentage, there is approximately 30% of older population was being exposed to involuntary weight loss, 25 to 50% of hospitalized older adults, and more than 50% of nursing home residents. Now we are talking about the etiology of involuntary weight loss. We can simply divide it into something chronic illness and acute illness. Something when we talk about chronic illness, we talk about congestive heart failure, chronic obstructive pulmonary disease, renal failure, chronic infection, inflammation, and other conditions. This constitute about 50% of involuntary weight loss among the elderly, and 20% of neoplastic, also other 24 idiopathic, including sarcopenia, which is something associated with age. Sarcopenia simply mean to lose muscle, okay, and 10% of psychosocial conditions. When we want to evaluate someone with nutritional syndrome, we have to be careful in documenting weight over time, and we have to something routinely done. You have to take a detailed history. It's something logical to take is dietary history and psychosocial element, because it affects the type of food we eat and the amount of food we eat. And by means of routine, we means also physical examination, and we should take a focus additional testing depending on what we found in the history of physical examination, and we take very careful regarding the treatment of the underlying cause, and also appropriate follow-up. And the nutritional therapy should include dietary education, removing dietary restrictions for the chronic conditions, nutritional supplement that given between meals, and multivitamins and multi-mineral supplements. Now we will talk about obesity as a part of nutritional syndrome. As I mentioned earlier, it's not just underweight, it also means who are obese. And we all know that obesity is defined when BMI is 30 or more. And obesity associated with hypertension, diabetes mellitus, spectrum of cardiovascular disease, OSP, OSA, and osteoarthritis. And the adverse outcome of obesity include impaired functional status and decrease in general health, which mean increase in mortality. Prevalence of obesity has increased in all age groups, in also post-gender, and all racial and ethnic groups. So what is the treatment for obesity? The goal here is very simple. If one have obesity, we just set our goal to 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 achieve a healthy weight, to improve his general health and quality of life. In terms of treatment, we use a combination of diet and behavioral modification and encourage increase in physical exercise. And for older people, we should emphasize the strengthening and flexibility rather than we just simply taking the approach of reduce weight. And National Institute of Health says that regarding older people, we should evaluate the potential risk and benefit in the individual patient to guide the management. Now we are talking about oral nutrition. To prevent undernutrition, something easier than treating. This is a general rule in medicine. Always, all the time, prevention is better than cure. What we need to do in case of nutritional deficiency, we have to enhance food intake, and we do this by evaluating, avoiding some of therapeutic diets, placing two or more patients together to eat in groups, which enhance their appetite and ability to take food, prepare food appropriately, and manage each case by case in term of an individual case, and giving adequate time for pleasuring. In terms of supplement, a nutritional supplement often decrease food intake, but overall nutrition intake increase due to nutrient quality and supplement density. And as Dr. Zainab mentioned earlier, it contains macro or and micronutrients, something available in liquid and powder forms. To select which type depend on patient preference, his general condition, and the ability for chewing food, and cost effectiveness of the type of food itself. Regarding the current evidence of nutritional supplement, there is poor evidence of sufficient supplement for homebound older people or well nourished older people. So we don't need to just give him supplement for who is staying at home or well nourished. Something obvious. In terms of usual micronutrient supplement, something growing. Approximately 60% of all the adults take self-prescribed dietary supplements. And surprisingly, many vitamins and mineral supplements are commonly available in supermarket and drugstore and safe, except when we taking it as excessive. Because some of them have potential to toxicity like vitamin A and D and iron. The evidence regarding supplements, as I mentioned earlier, it's very poor. There is very poor and insufficient data for many nutritional supplements regarding their benefits. Now we will talk about vitamin D deficiency. And vitamin D deficiency occurs in 30% of individuals more than 70 years of old, and it is associated with impaired calcium absorption and also reduced physical activity. The U.S. Protective Service Task Force says that there is insufficient evidence for screening vitamin D deficiency in asymptomatic adults. Maybe something appropriate for all the patients at risk for deficiency like weight loss or malnourished elderly people. And the current recommendation for all older adults include daily intakes of calcium and vitamin D for prevention of osteoporosis. In terms of drug treatment for undernutrition, there is no report demonstrating involvement in long-term survival, and it may cause serious adverse effects. And these adverse effects are associated with medication itself, and most of them are off-label, like nifezibine, Cipro, and other drugs listed here. In terms of cultural approach for nutritional care, we should know that ethnicity and religion affect our consumption of food, play a big role in terms of food preference and dietary lifestyle. Also, nutrition and aging are something connected to each other because each other affect the other. For culturally appropriate nutrition and education materials, this website are available for anyone who need to read more about it. Now I'm talking about legal and ethical issues. In terms of legal and ethical issues, food and fluid should always be offered to all patients as a rule of thumb, and the decision to start or discontinue artificial nutrition or hydration must be considered very carefully. For competent adults, they may choose to forego artificial feeding, just as they have the right to decline any invasive procedure. As we all know that patient autonomy is one of the ethical principles. And in case of advanced directive, we should honor patient wishes and value for to declare any mean of intervention. And for those without advanced directive, we just simply follow the rule of ethical guidelines. If there is no advanced directive, we just go to an adorable attorney or next of kin, and you all know that. Current evidence does not support the use of feeding tubes in patients with end-stage cancer, dementia, or chronic obstructive pulmonary disease. And regarding the palliative care, including emotional support, etc., something extremely important at the end of life. So, to summarize, we talk about nutritional concern and its effect on general health of elderly people and the acceptable parameter to assess nutritional status and tools to help screen and assess nutritional deficiency and the cultural and its role in terms of nutritional intake and the decision to start or discontinue artificial nutrition. And I think now it's time for quiz. About 5 cases and need to be something interactive. I can't just read it and go home. Anyone to read this case? Hello. Anyone, please? Hello, Zainab. Can you please share your screen? I think I have problem with my screen. Zainab, are you there?
Yes. No, just a moment, please. Let me. Where is my screen? Okay.
Yeah.
All right. Okay.
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 Tell me.
So we're talking about the first case, right?
Yeah.
Okay. An 88-year-old man comes to the clinic because of unintentional weight loss over the past year. He has lived alone since his wife's death 12 years ago. He is accompanied by his son. His son has managed his finances for the past 12 years. The patient is otherwise independent and continues to drive himself. The son says that his father is less active socially than in the past and spends most of his time watching television. The patient says that he eats and sleeps well, he's not depressed, weak, or dizzy, and has no change in bowel habits. He has had no surgery or serious illness in the last 10 years, and he takes medicines regularly. Colonoscopy done 2 years ago to evaluate minor hematochezia was normal. Examination findings: he's 73 kilograms, which was 14% lower than last year. Remember, we said a weight loss of 10% or more. But his BMI is normal at 23 kilograms per meter square. Everything else on examination is normal. Fecal blood test is negative. Score for mini mental state exam is 28/30. And for the PHQ is 0, so no symptoms of depression. Lab findings: normal urinalysis, CBC, electrolytes, normal liver, kidney, thyroid, everything's normal. Normal chest radiograph, normal sinus rhythm on EKG. So what would you do for this patient? Mm, so the options are no further diagnostic testing. We want to do a CT or upper and lower endoscopy or low dose dexamethasone suppression test. So actually no further diagnostic testing is indicated in this patient because all your preliminary tests point that the patient is otherwise normal. The second case is an 81-year-old woman who was admitted to the hospital 3 days ago because of hypotension, depressed sensorium, and urosepsis. 5 weeks earlier, she had a perforated gastric ulcer and sepsis. Her post-op course necessitated prolonged stays in the hospital and nursing facility. In the current hospital stay, she responds to IV fluids and antibiotics, and she's now alert and cooperative. For the last 2 days, she has been on her regular diet with polymeric oral nutritional supplement. The nurses notes that her nutrient consumption ranges from 25% to 75% of her meals. Her weight is 64.4, which is down from 69 3 months ago. But remember, she's been sick. So her BMI is still normal at 21.6. She has a surgical wound which is not inflamed and is being allowed to heal by secondary intent. She has 4 plus pretibial, thigh, and presacral edema, and her serum albumin is low. Remember, we said less than 3.5 is not a function of nutritional status by itself, but could be a poor prognostic factor of poor wound healing, especially in hospitalized patients. So which of the following is the best option at this point to determine the patient's need for additional nutritional support? Do we screen for nutritional risk? Do we obtain the prealbumin? Do we order calorie counts for 3 days? Or measure her biceps and triceps skin fold thickness and arm muscle circumference? So we order calorie counts for 3 days. So it shows that because she's sick and she's only eating between 25 to 75% of her meals, it shows that it is mostly an intake issue. So we will actually keep a close eye on her calories to see how much she's eating, and what else do we need to supplement from there. The third case is a 69-year-old man who was transferred to the medical unit after spending 6 weeks in the ICU for ventilator support related to post-influenza pneumonia and acute respiratory failure. A feeding tube was placed 4 days ago before transfer to the medical unit. The patient was started on a polymeric feeding solution at full strength. The target rate is 70 mils per hour, but the feeding rate has not been increased beyond 25 mils because he developed multiple liquid stools daily. Despite the effort to identify the causes of the patient's anorexia, his volitional nutrient intakes remains near zero. He has no history of C. difficile infection, and there was no case in the ICU of CDI or in his hospital ward in the last 2 weeks. He has had no nausea or vomiting, abdominal pain or cramping or tenesmus. He is not taking medication that contributes to diarrhea, and contaminated formula has been excluded. Before he was hospitalized, his weight was 72, his BMI was normal. On examination, he's alert and oriented. His temperature is normal. His weight 64. He has rhonchi. Remember, he was admitted for pneumonia. His JVP is 5. Heart sounds are normal, no S3. Abdomen is flat, soft, non-tender, normal bowel sounds. Fecal testing for blood is negative. Trace pretibial edema bilaterally. Functioning tube is PEG tube is placed and feedings are delivered at 25 mils an hour. His albumin is slightly low. His prealbumin is within normal, which reflects more acute changes. Serum sodium 144, blood urea nitrogen, creatinine normal, phosphate is 3, white blood cells 5.8, and hemoglobin 10.4. Findings are negative on the stool samples are negative for C. difficile, glutamate dehydrogenase, and AMB toxins. A swallowing evaluation is ordered. So which of the following should be done to improve the patient's nutritional status? Can we prescribe loperamide to stop the diarrhea? Should we take the patient off enteral nutrition and put him completely on parenteral nutrition? Should we start a dysphagia diet with hand feeding or refer for a jejunostomy tube? So the answer is we prescribe loperamide. Since we have ruled out infectious causes for the diarrhea, it is important that we stop his loss so that it can improve his nutritional status, his appetite, his fluid balance, and also stop the diarrhea. All right, well, and that brings us to the end of the presentation today. Thank you so much for listening. If anybody has questions, please go ahead and ask.
Hello, everyone. My name is Aya. I'm going to be presenting about pain management. First of all, I would like to thank Dr. Nader for this great opportunity and his constant support. And thank you, Dr. Zainab and Dr. Ahmed, for this amazing presentation. I'll try to be brief, and I hope that everyone can follow along and enjoy this presentation. I'll talk about the basic pain management principles related to types of pain, how to recognize pain, and how to use pharmacological and non-pharmacological pain treatments. So my objectives are that we understand how the management of pain affects the quality of life of the LTC residents. LTC stands for long-term care residents. To develop an awareness of misconceptions and consequences of untreated pain, to recognize different types of pain and identify appropriate analgesics for each type, to also utilize pain assessment tools as needed for facility residents, understand how to determine correct doses of analgesics as the residents' needs change, and to understand that all team members have a role in assessment and treatment of pain. So in general, what is pain? Pain is what a patient says it is, so it's totally subjective. So you can't into this. You just have to take it from the patient or the resident himself. In LTC, residents do not always verbalize their pain, but express it in other ways. And they tend to have more than one source of pain, and they're at increased risk of drug interactions, which tends to increase the likelihood of them experiencing pain. So pain is common at the end of life as a result of many things like arthritis and cancer and many other things. And like we said, everyone experiences it differently. Specifically, older patients tend to report pain differently. And institutionalized elderly are often stoic about pain, which means that they endure pain without showing their feelings or complaining about it. So one person's report of severe pain may seem like almost nothing compared to another. So the most important thing is that residents' self-report of pain is the single most reliable indicator of pain. So what the resident says is the most important thing. All LTC staff and residents' family share in the role of pain management. So it's like a teamwork. And everyone who's involved in the care of the resident must be able to recognize and report pain. And residents may not have pain when not moving. So like if they're just bedridden and they're not moving, they might not experience pain. But their caregivers can report pain when he or she is moving, when the resident is moving, or when they're doing their activities of daily living. So the quality, in general, in any LTC facility, the quality of pain control will be influenced by the availability of pain management programs and trainings, expertise, and experience of its members. These are some of the misconceptions about pain. So all of these statements are incorrect. Like the caregiver is the best judge of pain, which is, like we said, the resident himself is the best judge of pain. It's completely subjective. A person with pain will always have obvious signs such as moaning, abnormal vital signs, or not eating, which is not true because it does not always necessarily show obvious signs. And that pain is a normal part of aging. It's not a part of aging. Addiction is common when opioid medications are prescribed. Morphine and other pain relievers should be reserved for the late stages of dying. Morphine and other opioids can easily cause lethal respiratory depression. Pain medication should be given only after the resident develops pains, and that anxiety always makes pain worse. And the problem with these misconceptions is that they tend to hinder the process of us realizing that the resident is in pain, and so we won't manage it properly. So what are the consequences of untreated pain? It has many consequences on the resident himself, like poor appetite and weight loss. It can disturb their sleep, their mental health, anxiety, depression. It can even affect their difficulty walking and transferring, so they can become bedbound, which can increase their risk for skin ulcers, incontinence, decreased ability to perform their daily activities, and impair their immune function. And generally, pain is categorized according to duration into two categories: acute pain and chronic pain. And chronic pain is further categorized into chronic cancer pain and chronic non-malignant pain. So for the acute pain, it's generally brief and goes away with healing, usually 6 months or less. and it's not necessarily more severe. So if we say acute pain, that does not necessarily mean that it's more severe than chronic. And it may have a sudden onset or slow onset. And examples include like broken bones, strep throat infection, pain after surgery or injury. For chronic cancer pain, the pain is expected to have an end, and this end is either us curing it or with death. But there is an end that we expect. And it usually needs aggressive treatment, unlike acute pain, and addiction is not a concern. At this point, our concern is just to manage pain to the most optimum level. Chronic non-malignant pain has no predictable ending, in contrast to the cancer pain. And it's difficult to find a specific cause. It often can be cured because we don't really, and if it's frequently undertreated. And pain is also categorized according to its type into 4 types: somatic, visceral, bone pain, and neuropathic. For the somatic, the source of pain is usually from skin, muscles, or connective tissue, and examples include sprains, headaches, and arthritis. It tends to be localized, and it can be sharp or dull, and it worsens with movement or touch. And pain medications that can relieve somatic pain, it can be most pain medications, like any simple medication can help. However, if it's severe, then it might require a stronger medication. Visceral pain, the source of it is internal organs, and examples include tumor growth, gastritis, and chest pain. It's not localized. It tends to refer to other areas. It's constant and dull, and it's less affected with movement compared to somatic pain. And it usually needs stronger pain medications. Bone pain, the source of it is the sensitive nerve fibers found on the outer surface of bone. And it happens because, for example, when cancer spreads to bone, or when there's fractures or severe osteoporosis, it tends to be constant and worsen with movement, and it requires stronger pain medications like opioids and NSAIDs as adjuvant. Neuropathic pain, the source is nerves, and examples include like diabetic neuropathy, phantom limb, cancers that are spread to nerve plexus. And it tends to be burning, stabbing, pins and needle, shock-like shooting, and it's treated with opioids plus tricyclic antidepressants or any other adjuvant. So asking about pain is an important part of all assessment. Everyone who's caring for the residents should know how to report pain. And like we said, it's a teamwork, and charge nurses must assess all report pains. Charge nurses are the nurses that are like in charge. They tend to supervise a nursing unit, so they should report all pains. And assessment to identify and treat pain must be ongoing, because elderly residents require frequent monitoring for their pain. Residents with dementia or communication difficulties tend to pose an additional factor that hinders us assessing and managing pain properly. So in these situations, we need to be extra careful. We need to ask the resident if he or she is having pain. We need to consider the disease condition and procedures that may be causing pain, and think, if I were that resident, what would I want something for pain? So we need to put ourselves in their place. We can also use proxy pain reporting by a family member or staff, which is like when someone reports pain as if they were the patient themselves. So they're going to put themselves in the resident's place and tell us what they think the resident would want. We need to be alert for behaviors that may indicate pain, because they have problems communicating their pain. So we need to be extra careful with facial expressions, their physical movement, vocalization, if there's any social changes, aggression. And in general, when we're treating pain, the rules of thumb are, we need to start with the lowest effective dose by the simplest route. We need to start with a single agent and then maximize its potential before adding another drug. We use scheduled long-acting pain medications for frequent or constant pain, with per need short-acting medications available for breakthrough. And we treat breakthrough pain with 1/3 the 12-hour scheduled dose. If 3 or more per need doses are used in a day, then this means that we need to increase our scheduled dose, and we increase it usually by 1/4 or half of the prior dose. And when we increase the scheduled dose, we need to also increase the per need dose. Be vigilant at assessing the side effects of medication. So you need to be really keen and observant when it comes to side effects. Treat or prevent side effects like constipation and nausea, and change of medication as necessary, because sometimes we can't treat or manage side effects, so we might need to change the medication. Use the WHO stepwise approach called the WHO as we administer drugs in order. We tend to start with non-opioids like acetaminophen, and then move on to mild opioids like codeine, and then to stronger opioids like morphine. And we need to always reevaluate and adjust our medications as necessary. We don't stop pain medication in terminal patients. We just change the route if needed. Elderly present several pain management problems. So there are many problems when we're discussing pain management in the elderly specifically. One of them is that there's little attention in the literature for physicians or nurses on the topic of pain in the elderly. And like we said, elderly tend to report pain differently, and they tend to be stoic about pain. And also the factor of cognitive impairment, delirium, dementia, they all tend to present barriers to pain assessment. So educating staff is absolutely essential, especially when it comes to opioid use in the elderly. Opioid use produce higher plasma concentration in older persons, and it has greater sensitivity in both its analgesic properties and side effects. So we should start with smaller doses as required, and we need to consider the duration of action, formulation, availability, site profile, and resident preference when we're choosing the specific type of opioid that we want to give the resident. And we have to review for drug interactions. Older people may have fluctuating levels and require rapid titration or frequent breakthrough medication. Long-acting medications are generally suitable once steady pain levels have been achieved. And once it has been achieved, controlled release formulas can be used. So like fentanyl patches, but they should not be placed on areas of the body that may receive excessive heat, because it may release too much medication. And also they might be contraindicated with exceptionally low body fat. A frail elderly at risk for both under and over treatment of pain. NSAIDs and acetaminophen are effective and appropriate for a variety of pain. However, NSAIDs, their side effects include gastric and renal toxicity, especially in the elderly. Unusual drug reactions are more common in the elderly. So staff must be aware of side effects, and there must be an effective communication method for staff to know adverse drug reactions. So what everyone can do to manage pain. First of all, we need to show that we care. We need to talk to the resident, even if he or she doesn't understand, talk to and not around the resident. And make the room pleasant, try to take care of the basics like glasses, hearing aids, drying their clothes, toileting, food and fluids, and also communicate with the team. Let others know what works with this specific resident. And also always report pain. Pain, like we said, is not a normal part of aging. And we need to understand the care plan for pain. Pain management, like we said, is a team approach. We can also try using relaxation methods to decrease anxiety and muscle tension. We can also use tactile strategies like stroking and massage. Music, art, and meditations can be very helpful. And don't forget the team. We can also use physical therapy for mobility and safety, and occupational therapy for positioning and splints. So the following items are MDS items. MDS stands for minimum data set, which is it's a process that helps nurses make a comprehensive assessment of each resident's need and to identify their health problems. So it's divided into sections. So when we keep these things in mind, it can help us recognize pain, like their mood and behavior patterns. For example, if they have repetitive verbalization, anger, complaints, sad, worry, if they're verbally abusive, socially inappropriate, if they resist care. Another section is also their psychosocial well-being. So if they're in any covert or open conflict or repeated criticism of the staff, or if they're unhappy with their roommate, or if they're unhappy with other residents. Another section include their diagnosis, like what disease do they have? If they have DVT, arthritis, hip fractures, if they have any infection like a wound infection. And we should also assess their pain symptoms, their oral and nutritional status, their oral and dental status, and their skin conditions, if they have any ulcers, abrasions, bruises, etc. So there are certain state licensure. They require the facility to address the resident's pain. So they need to address each resident's pain. And the federal regulation requires facilities to make a comprehensive assessment. So we need to make a very detailed, comprehensive assessment for each resident according to their need, using RAI specified by the state. RAI stands for Resident Assessment Instruments. They're like instruments that help assess and identify the needs and the strength of each resident. It also requires facility staff to develop a comprehensive care plan to address pain. So we need to make a very comprehensive plan to address the pain that meets the residents' specific needs, mental and psychological needs. And it also requires staff to meet pain needs of the residents. So each resident must receive, and the facility must provide the necessary care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being in accordance with the comprehensive assessment and plan of care. Thank you, everyone. If anyone has any question, you can go ahead. Okay, I think Dr. Abulgasim is next.
Good evening. How are you? Do you hear me well? Okay. I'm hoping everyone is doing well. Today, we'll be talking about ePrognosis. I was supposed to be joined by my colleague, Dr. Ahmed, but he is having an exam tomorrow. So we should wish him good luck. As we know, managing patients and applying knowledge, whether it be algorithms or using scores, for example, like the Will score, is a very daunting task, something that's hard to remember. And this is much escalated when it comes to calculating prognosis for patients. And calculating prognosis is something that is more heavy, since it's what the patient usually wants to know. What is his prognosis after receiving a diagnosis or after having a lot of issues that he's complaining about. The limitations of traditional prognosis is most of the time you'd have limited time in order to reply to the patient about what he's complaining of. It's mostly subjective, a lot of bias can occur, attribution bias to previous cases and personal cases. It is more difficult to identify high-risk patients due to the subjective nature of traditional prognosis. As I've said, it's very time-consuming to use manual calculations, and due to its subjective nature, it has the potential for human error. And this is where ePrognosis comes in. It's a web-based prognostic tool. You can think of it as a calculator, similar calculator as the ASCVD, the atherosclerotic cardiovascular disease calculator that most of you should be familiar with. ePrognosis was developed by researchers at the University of California, San Francisco. This platform addresses the unique challenges in predicting outcomes and prognosis for elderly patients. How it works is that it uses patient data and having a large library of different tools and calculations in different populations. It will choose the most suitable tool and calculation and just give you the outcome outright. The key features of ePrognosis, firstly, as I've just said, it has multiple validated prognostic indices that are frequently updated with that new data that comes in and with published research. It's very customizable for patient characteristics, as we will see in a minute. It allows you to input the patient data, including his age, functional status, comorbidities. For some of the prognostic calculators, you will have option to add lab values such as creatinine and albumin, and it adapts the assessment based on specific clinical contexts. An example could be where he is now, whether a nursing home, in palliative care in hospital, or just living in his house. Concerning mortality risk estimates, it gives clear evidence-based estimate. As I've said, to choose the most relevant tool or instrument for your patient. It gives the result in an easy to interpret format and gives, for example, 6 months, 1 year, and 5-year percentage of mortality or disability. How would we use ePrognosis? Firstly, ePrognosis, as it has a couple of calculators. It has ones for screening decisions. I will enter a patient's data, and it will weigh the benefits versus the risk to this specific patient. And it will help bring an objective view when discussing the decision for undergoing screening with the patient and their families. Concerning treatment planning, there are some calculators that will help inform if, for example, this patient with this specific life expectancy should undergo this screening or this management approach. And it's very important and in my personal opinion, it's the most important part. It's the end-of-life care discussions, as prognosis is something that is usually sought by the patient when approach with the diagnosis. A very important notice is, and I copied it part of the site, is at the end of the day, whatever guidelines say, whatever tools you use, these, yes, are the most appropriate evidence spread out from large amounts of data, but at the end, you will need the clinical touch. You need to address how this intervention, this treatment, this information will impact your patient, and also taking into calculation the other aspects of his health and his life. I will start right out with a practical demonstration of ePrognosis. Do you have any questions? All right. This is simply ePrognosis. You can go and choose certain calculators. There is a full list of calculators that you can go to. It will provide you with many calculators that are included in this algorithm, and it's divided upon if he's living in the community, living in a nursing home, or hospitalized. And each will be targeted to a certain disease or a certain outcome that you're trying to calculate. And just here off the top of the list, for example, this calculator would be breast cancer risk assessment for postmenopausal women age 55 or older. But this list is not what gives ePrognosis its strength. The main strength comes in this simplistic approach. You have three types of things that you can measure. We will go one by one. I'll start at the right because it's the simplest one. And for example, we start with cancer screening. It's a very interactive platform, so it asks you, do you want to screen for colorectal cancer, breast cancer, or both cancers? Just for the sake of it, we'll go with both cancers.
Dr. Abulgasim,
Yes.
I don't think we can see the screen you're working on right now.
Oh, I'm very sorry. Let me fix it. Okay, can you see it now?
No, it's still on the PowerPoint.
You can.
Okay. How about
Yes.
now? All right. So I'll start this last part. As I've said, there is a full list of calculators that you can use. And it's divided according to if the patient is living in the community, living in a nursing home, or is hospitalized. And each of this would be targeted to a certain illness or prognostic outcome, and also correlated to the patient's age. And this is not where the power of ePrognosis comes from. It comes from the simplistic approach that won't take much time and would choose the best calculator for your current situation. These are the three calculators: prognostic calculators, time to benefit, and cancer screening. I'll start with cancer screening. So we have three choices: colorectal cancer, breast cancer, and both cancers at the same time. We'll just go with both cancers. Then you'll be asked information about the patient. So a few things that you can take from patient's history. I'll just go with a random case. I'll start with an extreme one, and then I will have for example, another one. Let's say he's more than 85 years old, female, male, let's say male. You'll then choose his BMI, less than 25 or more than 25, let's say less than 25. You will describe the patient's health in general, whether it's excellent or very good, fair or poor. Let's go with good. Then we'll go to more detailed medical history. Does your patient have chronic lung disease such as emphysema or chronic bronchitis? We'll say yes. And when we chose yes, now it asks us, does the lung disease limit usual activities such as household chores or require home oxygen? As we were going with an extreme case, you will just say yes. Has your patient ever had cancers? Yes. Congestive heart failure, we'll just skip this one. Does he has diabetes or high blood sugar, as it's prevalent in these populations? We'll go with yes. Then they'll ask you which best describes your patient cigarette use, and you have three options. He never smoked, never have been a smoker, he's a former smoker, or a current smoker. Let's go with current smoker. Then During the past 12 months, how many times was your patient hospitalized overnight? Still, three choices: none, once, or more than 2 times. Let's say more than 2 times to align with the extreme case. Because of physical, mental, or emotional problems, does your patient need the help of others in handling routine needs, such as everyday household chores, doing necessary business, shopping, or getting around for other purposes? As of the extreme nature, we'll just go with yes. Because of health or memory problem, does your patient have difficulty managing money, such as paying bills and keeping track of expenses? We'll go with yes. Because of a health or memory problem, does your patient have difficulty with bathing or showering? Yes. And because of health, finally, because of health problem, does your patient have difficulty pushing or pulling large objects like a living room chair? Yes. These are two indexes, the Lee index, and this is his score, 22, and the Schoenberg index, and this is his score. Then you'll just, after entering the patient's information, you'll press on calculate risk. For example, for this patient, I went very extreme, something he was having poor health with many comorbidities and large difficulty with activities of daily living. Obviously, it will be harmful to screen him. And most likely through another calculator, he would be having a short life expectancy. So first of all, it will show you the result. And as you see in this picture here, this meter, this is an extreme example of harm. If it's somewhere in this blue and the star, he would be in between. So in this instance, and we will have an example in a moment, in this instance, it would be better to discuss the patient and the relative risks according to his case. Then when you go down, it will give you more of a statistic approach and visual approach to that result for you to interpret. For example, they said of 100 of 1,000 people like this person who got tested for breast or colorectal cancer will experience harm in the first year. And 1 of 1,000 people would avoid death from breast or colorectal cancer, which means in his case, breast or colorectal cancer is very unlikely. And within 10 years, and here comes part of the prognostic calculation, 900 of 1,000 of patients similar to this patient would be dead within the next 10 years. So he won't be benefiting much from the screening. Here it just lists the benefits or harm for the colorectal cancer or breast cancer screening. Main thing, benefits would be if he has colorectal or breast cancer, it would be caught early and managed accordingly. Main harm is anxiousness from the test, uncomfort and complications that may occur from a colonoscopy or a breast cancer screening tool. We'll go back, and this time we'll be using somewhat of a moderate patient example to illustrate a different result. So I'll just go fast with it. Let's say female, leave the BMI. Excellent, very good. No emphysema, no cancers. Not failure. Yeah. Never smoker. Hospitalized overnight, 16 months. And no. Now, when you look, before we were having points in the 20s, now the points are 4 and 5 for Lee and Schoenberg indexes, respectively. Now we'll press again on calculate risk. Here for this patient, someone who's healthy, someone who's a younger patient with less comorbidities, it would be advisable for him to have screened. Going down to the visual representation of the results, it's quite similar, but the main difference is instead of 900 out of 1,000 would die within 10 years, only 200 out of the 1,000 would die within the 10 years. And similarly, it's showing the benefits of and harm of going with the screening for both cancers. This is the first calculator. We will go back and go on to the next calculator. Is there any questions in here? You can ask questions right away because I'm unable to see the chat. Okay, moving on. We'll move to the time to benefit calculator. And it's by far my favorite because it's very easy. You'd have to calculate the patient's life expectancy and with an easy visual representation according to his life expectancy, you just move it horizontally to align with the patient's. Okay, now I'm having some difficulties. Okay. Okay, I'm having difficulties moving the slider, but the general idea is you'll move the slider towards the targeted or the calculated life expectancy. And according to the life expectancy, it would recommend the green boxes down here, or it does not recommend having a certain screening intervention or such. These are the interventions or the screening tools that could be used, for example, colorectal cancer screening, mammography after breast cancer, finasteride for BPH. These are some of the treatments. Bisphosphonates for osteoporosis, an intensive glycemic control approach, intensive blood pressure control, statins for primary prevention, hospice admission, and if the slider was helping, you'll see that for hospice, it's at 6 months, which is the recommended time frame for hospice admission. Then when it comes to the depression, very contrasting with the other parameters for the interventions and screenings. For one with a very short life expectancy, it's recommended that he takes methylphenidate. For ones with more than weeks of life expectancy, it is recommended for him to take an SSRI for depression. And these are the calculators and the references attached to these that is derived that this calculator is derived from, and for each of the parameters that we just went over. Finally, we will go to the last prognostic calculator. And this one is the most complex, the one with the most needed patient data. So first question is, where is your patient? Is he living at home and coming to the clinic? Is he living in a nursing home? Is he in the hospital? Or is he in hospice or in palliative care? We'll just go, for example, the nursing home. Then, does this patient have dementia? Let's go with yes. And as we've seen, we're just going with random patients. Then you will have similar questions and somewhat not very similar to that first calculator. Has your patient been admitted to the nursing home in the past 90 days? Let's go with yes. How old is the patient? Let's go with around 70. What's the sex of the patient? Female. Does your patient have shortness of breath? No. Does your patient have at least one pressure ulcer that is greater than or equal to stage 2? As you see that, ulcer staging according to the depth of the ulcer and its borders. I would say no. Is your patient totally dependent for all activities of daily living, including bed mobility and eating? Let's say, no, he's not totally dependent as he's in a nursing home. Is your patient bedbound most of the day? No. Does your patient have insufficient oil intake? We'll just leave it as lower patient threshold, so we'll go with no. Does your patient have bowel incontinence? No. Is your patient less than 18.5? Is it anorexic? No. Or cachexic. Has your patient experienced recent weight loss? And this is defined as more than 5% body weight in the prior 30 days or more than 10% in the prior 180 days. You'll go with no. Does your patient have congestive heart failure? According to these questions, there are points assigned to each question, and this is the total point for this calculator, for example. Then, similar to the first calculator, you will press on calculate risk, and it shows you, based on the point system, 6-month mortality for this specific patient is 7%. We'll go back in a moment and have a more extreme patients to see the contrast. So for this patient, it's a 7% mortality. As the points go up, the risk for 6-month mortality goes up. Here it gives you some information about the index and how it was utilized. Let's go back and have a much extremer example of a patient. He's been admitted, for example, for a longer time. Sex will change to mild. Shortness of breath, yes. Pressure also, yes. Dependent, yes. Bedbound most of the days, yes. Insufficient oil intake. Bowel incontinence, BMI of less than 18.5, and experienced recent weight loss. And let's align with the heart failure, with the shortness of breath and say it's from congestive heart failure. As you can see, the total points now shifted from 5 with the previous patient with few comorbidities to 23 for this patient with a rather extreme case. We will again calculate the risk, and as you've seen here, the 6-month mortality for him is quite high with 49 to 62%. This is a quick demonstration of ePrognosis. I'm hoping that you've understood and that you'd go and try to use it yourself just for knowledge's sake or just out of curiosity. Do you have any questions? Okay, thank you for joining me, and I would leave the mic or the screen in this case to my colleague, Dr. Anab, who will be talking about conferences. Thank you.
Hello everyone, I am Anab Jabir, and I will be presenting I'm going to present appropriate conferences and annual meetings for fellows. I'm honored that I'm presenting this presentation in front of you, and I will just start and I will try to be as quick as I can. Okay, I'm sharing my screen. Okay, so appropriate conferences and annual meetings for fellows. I'm going to focus on geriatric conferences A quick overview. I'm going to start with a quick introduction about benefits of attending medical conferences. I'm also going to go through a little bit of tips on how to identify the right conference for you if you're going to attend the conference. And then I'm going to mention some of the best examples of the appropriate conferences that us, the fellows, can register for and present our work in. Okay. So what are the benefits of attending medical conferences? The first benefit is the continual learning and knowledge that the conference gives you. Medical conferences are important for the dissemination of the latest research and advancements through presentations, discussions, and poster sessions. Attendees gain insight into cutting-edge advancements, innovative treatments, and evidence-based practices. And it's also important to stay updated with the latest advancements because it can improve the patient care. It can lead to evidence-based practice and foster a culture of continuous learning and improvement. Conferences also gives you a great opportunity to build up your network by meeting peers, senior professionals, and potential collaborators from various corners of the globe. This can open the doors for you for research collaborations, career opportunities, and enriching professional relationships. And who knows, you may match into the program of your dreams just by attending a conference. So yeah, it's important. Okay. It helps in giving you a feedback and improvement of your work, because when you present a research at a conference, you allow immediate feedback from peers, which can improve the quality and impact of the research. It allows for the opportunity for the discussion and debate by engaging with the audience and other presenters. This can lead to a constructive debate, fostering critical thinking and refinement of ideas. It will also aid in the professional development through the workshops and presentations at the conference. You will enhance your skills and you will stay updated with the latest techniques and technologies. A lot of conferences also offer continuing medical education credits, which are essential for maintaining professional certifications, even after the conference ends. So, here are just some tips to identify the right conference for you. You need to define your objectives. You need to clarify your goals if you are attending a conference to present your work, or you are attending a conference to stay updated with the latest research, or you are just attending for networking. You need to identify the specific topics or field of interest. You need to look for the research conference details. It's better to look for well-established, reputable conferences. It will be great if you can check for the organizing body, whether it's professional societies or academic institutions. And it's important to check for the conference history and frequency. You should check and review the agenda and speakers to ensure the program that covers the relevant topics for you to meet your objective for attending the conference. And you should check for the leading experts and influential researchers among the speakers. You should, of course, consider the location and format by deciding the preferred location for you. And you should choose between an in-person or virtual format. Okay, so many conferences have different opportunities for participation, like oral presentation, poster presentation, or panels. And you should also examine the costs, and you should make sure that it's cost effective. to participate in a specific conference. Okay, it may be good to seek recommendations from peers, colleagues, or mentors for specific conferences. And you must also check the publication opportunities. Some conferences publish proceedings or offer journal submissions. And you might want to consider the impact factor of these journals. Okay, so going to the main point, appropriate conferences and annual meetings for fellows. For us, I'm going to focus on geriatric conferences, starting, of course, with one of the most important conferences in the field, the American Geriatric Society Annual Scientific Meeting. I'm just going to cover the main points of each conference. For the sake of time, I'm just going to speak a little bit about the organizers, about the timing and location of each conference, and what are the participation opportunities look like. I'm going to speak a little bit about the costs and how to attend the conference. Okay. So American Geriatric Society Annual Scientific Meeting is organized by American Geriatric Society. It focuses on advancing the health, independence, and quality of life for older adults. Key features, there are scientific sessions that provide the cutting-edge research presentations. There are also workshops that provide practical hands-on learning opportunities. You can also find in-depth discussions on specific topics. There are also poster sessions where you can find visual presentation of research findings. The conference also provides exhibits to showcase the products and service related to geriatrics. So the timing and the location for the next meeting, it will be in May 8th to May 10th, 2025, of course. The pre-conference day is on the 7th of May, and it will be in Chicago, Illinois. Regarding the participation opportunities, there are oral presentations, poster sessions, networking events, mentorship programs. Okay, regarding the costs, I have put the costs in front of you, so you can check. You can make sure that the conference provide you the greatest benefit. Okay, so how to attend? Like every conference, there are early bird, the regular registration options. There are guidelines in place for submitting research abstracts if you want to submit an abstract. There are travel grants available for eligible participants. According to the rules, you can check all these rules, and you can check their website for more information. I think a lot of the fellows a lot of previous fellows have participated in this conference. Okay. The second conference that I'm going to talk about is the Society for Post-Acute and Long-Term Care Medicine, the AMDA annual conference. It's organized by the Society of the Post-Acute and Long-Term Care Medicine. It focuses on improving care in post-acute and long-term care settings. It also provides scientific sessions, workshops, symposia, poster presentations, and exhibits. Regarding the timings, it will be from March 13 to March 15, 2025 in Charlotte, North Carolina. Participation opportunities. There are also oral presentations, poster sessions. There are also opportunities for networking events in social media and so. And they offer mentorship programs too. Here are the costs for regular registration and early bird registration. Okay. And again, we have early bird and regular registration options. You can apply for abstract submission, and you may be eligible for travel grants. To check all of these, you can visit their website that I have put in here. The third important conference that I'm going to talk about is the American Society on Aging Annual Conference. It's organized by American Society on Aging. It focuses on enhancing the knowledge and skills of those working with older adults. And it serves the purpose of knowledge sharing by presenting the latest research and innovations and best practices in aging. It provides you with the opportunity to network and connect with professionals, research, and practitioners in the field of aging. And it will also enhance your skill and knowledge through sessions and workshops. The timings and locations, it will be from April 21 to 24th, 2025 in Orlando, Florida. And it also have various participation opportunities from oral presentation to poster sessions, network events, and mentorship programs. Here are the costs for the registration. And like the previous conferences, it provides the opportunity for abstract submission, and you can also be eligible for a travel grant if you participate. And here is the website for the American Society on Aging Annual Conference, the official website for more information. Just going to talk on a brief note about other conferences and meetings. There is the American Indian Elders Conference. The next meeting will be from 29th of September 2025 to the 3rd of October 2025 in Durant, Oklahoma. Here is the website for more information. And also, there is a meeting for National Adult Protective Services Association. This meeting is held in the second Thursday of each month from 2 to 3 p.m. Eastern Time. And here is the website if you want to attend. Thank you. Thank you so much. If you have a question, I will be happy. Okay, thank you. Thank you, Dr. Nader, for this opportunity. Yeah, Dr. Faiza.
Yes, hello. I just had a question. So when we register for these conferences, do we do the early bird or like as a student, or do we register for the non-member category?
I think it differs mainly in the cost. When you register as an early member, as an early bird, you get a lower cost, of course. But the later you register, the more you are going to like pay. Yeah. But what differs the most is if you are going to do an abstract submission or do an oral presentation, you must be updated with the deadlines for submission. I tried to update these things in here, but they are not available yet because these conferences are still in the future. So I didn't find the information in their official websites. Yeah.
Okay.
I hope I answered your question. Yeah, thank you.
Yes.
Another question? Okay, thank you so much. Thank you, Dr. Nader, and goodbye.
Thank you so much. This great presentation. All of the presentations were great. Thank you all. Any updates? Any questions or comments, anything else regarding the fellowship, the program? Go ahead, Dr. Faiza.
Hello, Dr. Nader. So I had a question, not regarding the projects update, but just, regarding the conferences. When they say they have a CME hour, option, so can we avail to that? Because in the future, say if we might need to register for a temporary state license, there are some regulations that they say, okay, you need a certain number of CME hours. So can we avail that opportunity to attain CME hours, or is it not required for us?
I don't think it's required for you, and you can obtain it. In the past, I used to get these hours and certificates, but I don't think it will play much in your application. As far as regulation per the state, yes, different states, they have different requirements, like 50 hours, 100 hours, 75 hours of continuing education. So this is when you already started the residency or the fellowship or kind of training. You already registered with the state. So from the starting point until 1 year or 2 years, you have to collect a total number of how many, 50 hours, something like that. So by the second year, you have to do this, or by the third year, you have to but you are not there yet. So when you start your residency, this will be an advantage that you can take when you attend these conferences. But for now, it's optional. You can collect and you can save it for your own purposes, but I don't think it will count or it will benefit much as far as state regulations.
Okay, thank you, Dr.
You're welcome. But you can put it in your resume. You can put that you attended this type of conferences, especially if they are some unique or institutions are well known. And so if you go to a conference at Harvard, for example, if you put it, that might have a weight on your resume. Any other questions? So for the newcomers or the new fellows, we welcome you first, and we have a schedule where you can go on the app and then see your team. Each team, they will have a date where they will present, and if you want to present in a day that's not your day, or you are available, let's say, in 2 weeks, and this is a different team, you can approach the team leader or team members of that team, and you can do the same way the presenters did today. So 2 presenters or maybe 3 presenters can handle one topic, so you can contribute that way. I don't see other questions. I have one thing to share with you. So I'm gonna share my screen here. So in the coming weeks, I know some of you will be going to apply through ERAS. So I'll be happy to help you guys writing the letter of recommendations. But I want your help. So what I want from you is you want to tell me what activities that you participate in. For example, if you presented a topic, or if you completed some task in a project, or you started a project. So I want you to list all you can for me, so that the letter, when I write it, it will be personalized to your accomplishment or whatever you gain through this program. So to do that, I want you to open the app, and the second tab here, if you click on it, it will have update my task or projects. And then you can click on it. You can put the name that you want the letter to be written with your name. Sometimes your name might be different on our system or our record. Sometimes you want to put your 4 names, first name, middle, and last name, something like that. So I don't know how you put your name in your applications, but I want you to put it somewhere here so that I can copy paste that name the same way you want. Instead, I complete a letter, send it, and then you tell me, oh, this name is wrong, something like that. So we don't want to get into trouble for that. The second part here is the bio, or what you have achieved. Hopefully you will be able to say something about the projects that you are involved, either presentations, mobile application development, involvement in abstract, involvement in manuscript, whatever you think you participated in, small groups, discussion, training, workshop, anything that webinar you did, if you can put it here, and you can hit submit when you are done, and it will be listed. And you can update that every now and then according to your needs. So I will look at, when you request a letter, I will come here, look at your achievement and see what you did, and I can manipulate that or tweak that in the letter so that we can highlight your achievements. If any questions, please let me know. I hope the team leaders will look at this section of the recording so that they can share this information. Those who are here attending the meeting, if you can share that as well with the other people who will be applying. And I wish you all the best. Thank you so much. Dr. Lima, go ahead.
Sorry, Dr. Nader, that's one point to mention here. Thank you for sharing this. So I will share it with my group as well. But my question is it be helpful if I mean, any of the project leaders can share their project members list under the project name and send it to you so that, I mean, it can show who is participating in the project. It may help. I'm just thinking about that because we're working 2 projects right now.
So the easiest way is to add that in the project list. So when, can you give me a second? Just a second, I'll be. Sorry about that. So the easier way for the program, the project leader is to go to the project tab. And I'm going to add somewhere here. You can add a new project, and you can add the title of the project and who is the participant. So this is one way. But for the fellow who is going to apply for the residency or ERAS, I think the best option is to put it in their profile or biography, so that when I want to write the letter, it will be containing all the information that the fellow wants me to display or to share, if that makes sense.
Yeah, okay. Thanks so much, Dr. Nadir.
You're welcome. Good question. Any other questions?
Yes, I remember.
If not, we're gonna end the meeting today. Thank you so much, everyone. Thank you all the presenters from today's meeting. We'll see you next week. Assalamu alaikum. Have a good day.
Thank you so much, Dr.
Thank you,
Nadir.
Dr. Nadir.
Thank you, Dr. Nadir. Thanks so much.
Thank you, Dr. Nadir.